Welcome back to session 4, which is on opportunities to improve equity research. And first up, we're going to have Associate Professor Nevil Pierse, who is the co-director of He Kāinga Oranga in the Department of Public Health in Wellington. Nevil is a statistician who's been working since 2012 to understand the effects of housing and homelessness on health and well-being.
Kia ora koutou katoa, ko kanokanor te monga, ko shana te awa, ko Ngāti Irish taku iwi, ko minagahan aho, ko Nevil taku inua. Thanks very much for the opportunity to speak. Thanks to Michelle for organising it. Thanks very much to Kim for your kind introduction. I'm going to be talking about housing, improving housing for health and equity. So just a little overview about what I'm going to be talking about before we get into it. And the most important thing here and with all our research is to do that it's done in partnership, and the principles of Te Treaty, which are really, really good and really helpful for telling us how to think about and how to do our research and how to do the process as we seek to improve equity and equitable outcomes. So it's really important that we do partnership, and all our work is done with partnership. And what's helped me learn the most through my research has been our partnership with local communities, and especially Maori communities and whānau ora providers up and down the country have been really useful. I want to talk about equity, not just health equity, but equity in terms of, because you can't have health equity without equity in terms of wealth and quality of lifestyle or well-being, and this is both by ethnicity and income. Mostly I'll be focusing on Maori Pākehā, on Maori inequities, but it is important to have a broad view of what equity means. I'm going to talk a little bit about New Zealand housing, and I'm going to talk in about 20 seconds about what's 20 years of research by myself, Kim, and the rest of our He Kāinga Oranga team. I'm going to introduce two things that I think are really making a difference here and really improving lives: the Healthy Homes Initiative and Housing First, both of which I've had the pleasure of researching with local communities. First of all, just when you look up the definition of equity, and we all know it, or we all have an idea of what we think about equity is, but if you Google it, you'll get a severe land as equity is a share of something. And equity is a shared interest in a financial product or something of financial value, such as a housing. That is the Google definition of equity. And just when you're talking about equity of financial assets and equity of wealth, the single biggest financial asset category is housing. That is true of all of the developed world and has been true of all of the developed world since about 1890, when it overtook agricultural land. So when we think about equity in housing, we have to think about the right to own the wealth that is the housing, or the right to the housing services that are generated by the housing we have invested in. And unfortunately, with the housing crisis in New Zealand, this is getting further and further away from those who don't have income and other sources of wealth. Getting housing equity has never been as far away as it is currently. Then when we do have housing, and in particular the housing we have in New Zealand, I often sum up the housing in New Zealand when I'm asked to sum it up in one word. I use the word crap. Half of New Zealand houses are adequately heated. About half of them are adequately ventilated. About half of them are adequately have adequate insulation. About half of them are mouldy. Each and every one of these categories is worse for rental housing rather than owner-occupied housing. We have a severe housing quality problem in New Zealand, and this drives health. This drives our health problems and our health, and through the inequities in housing, we drive the inequities in health. Interestingly enough, these are easily fixable. Our first big study showed a randomized controlled trial of insulation. We randomly insulated 700 New Zealand homes one year, and then we waited a year before insulating another 700. So we had a year's difference where we knew the only difference between two groups of houses was that we had insulated them at random. The biggest finding of this is insulation raised the temperature. This is exactly what it's meant to do. But then by raising the temperature and by raising the internal environment, the environment that people are spending most of their time, they had less self-rated poor health, they had less wheezing in school in the last 3 months, the children had less days off school, the adults had less days off work, everybody had less visits to the GP and less respiratory hospitalizations. Simple changes in housing quality make a difference. Insulation made a difference. Similarly, when we changed the internal environment by improving the heating, that has the same effect as raising the temperature by insulation, as does giving people the energy vouchers or moving them out of energy poverty by paying for their power bills and their ability to heat their homes. You can get a range of better outcomes. Similarly, in our homes, injury prevention is one of the things that's very much underlooked. And injury prevention can prevent injuries. There are a range of basic household quality improvements that can be used to drive health improvements. This is well known to all the communities we work with. And one of the pleasures of my job, one of the absolute pleasures, is going to explain our studies to our participants, and especially when we were doing the randomized controlled trials, saying, well, we're going to have a look and we're going to randomly fix this one aspect of the housing. And everybody repeatedly said, well, there's a whole pile of linked problems. Why not fix them all together? And the community have been driving us to do this for quite a long time. So about 6 years ago, we've gotten together, and this is in the Wellington version of this, of the Healthy Homes Initiative. Well Homes is led in part by Cokery Marai, which is where I was in the earlier picture. And this is where a child has been hospitalized with a housing-related disease. Going to that child's home and seeing with a social worker or a community worker, somebody who knows their stuff and we've trained up about housing, looking at the housing problems. If that child is hospitalized for a housing-related disease, going to the house to look at the housing problems and trying to diagnose the problems from the house rather than from the hospital bed. And that has shown us what needs to be done in the basic things. Nearly 70% of the kids we look at in our studies don't have inadequate, non-existent or moldy beds and bedding, and that needs to be replaced. Similarly, carpets, curtains, heatings, installations, minor repairs, and then making New Zealand's systems that are welfare systems that are broken and at the point of collapse work at least as good as they're meant to. So this is MSD and making sure MSD is on board and that people are on the benefits they're entitled to, and then making sure that they're in the correct place for housing referrals and social housing. Unfortunately, New Zealand has a big lack of social housing and an even bigger lack of quality social housing, something we're going to have to remedy. So working with the providers is really cool, and they've given us an insight, and in particular, one of their insights about people's thinking is just how normal it's become and how normal people think that the poor quality of New Zealand housing is. When you haven't experienced anything else and you haven't experienced housing that's enabling and helping you move forward, it can be you don't think of it. You can struggle to think of what it's like not to be sick. The success factors, as identified by the community, are that it's collaboration and that we're working together, that we're visiting the home, and then that nothing, and this is a big part of the success of the Healthy Homes Initiative, that nothing is outside, that everything is integrated together. And this is very much coming from the FANA Aura model, and that these are the problems we need to help a family, rather than just trying to do one intervention at a time. Some of the barriers we have are landlords' reluctance to help, poverty, and some people even with support in the government schemes, there are some problems that are too big, and then mostly the lack of social housing. I'd like to think there are currently 13 providers up and down the country of Healthy Homes Initiatives, all of which have given me their data, and I really like to thank them. They've given me the data. They've trusted me with the taonga that is the data of their 24,000 referrals in. And we've worked out We've worked out who these people were, when they were. We've asked their permission to do research on them, to look at the outcomes. But they've given me the data of who they were and which interventions were done when. And we have now started 2 weeks ago, or just before lockdown. We managed to link this to the integrated data infrastructure. So I'm really excited about where we're going forward. We've already had a look at the health referrals for a good sample of these, and an overview of who our population is. In particular, the population of kids that we're dealing with are majority Maori. The next biggest group is Pacifica, and then we have a trailing of all other ethnicities that are non-Maori, non-Pacifica. In some regions, this is even greater. Manoa, in particular, who are the Northland provider, have over 90% Maori participants. The houses we're looking at are predominantly in the private rental and housing New Zealand market. There are a few owner-occupier and quite a few people who are homeless, unfortunately. But when the Healthy Homes Initiative do spring into action, and after visiting these families, for every 10 children that we have seen, then year after, one less child was in hospital, 6 fewer pharmaceuticals were dispensed, and 6 fewer GP visits. And just looking at our pilot data from last year, from the 15,000 HHI referrals, that's already prevented 1,500 hospitalizations, over 9,000 GP visits, and over 9,000 pharmaceuticals that needed to be dispensed. The savings are in the region of $10 million a year to the health system alone. And that's on top of the value from the broader social benefit of having these kids rather than in hospital, having them in school, having their parents at work rather than looking after them, and helping the whole family. This investment pays back on itself in 2 years. So there's real improvements that can be made, and we are making real improvements. If we attack some of the inequities and the inequalities that we see in housing. And in particular, these inequities are very much layered on ethnic inequities and income and wealth inequities in the housing thing. But the group most behind and left behind by housing inequity is those who are homeless. There are some good principles internationally, and internationally there's a real movement for homeless people and for long-term homeless to look at housing first principles and to put together a program that based on housing is a human right and housing is a choice, and to give people their choice of housing in a harm reduction, non-judgmental way. Actually, when you look at it, while the Housing First internationally is a mainstream model and now come into New Zealand, this principles that this are espousing are very similar. The holistic and there's no problem outside it, equity and active prevention of things are very similar to the Whānau Ora principles. The idea, and Whānau Ora is a better idea, is to deal with the key difference is the collective whānau approach that New Zealand and Whānau Ora providers have been doing. And from a housing point of view, we'd really like to go to Papakāinga housing or even a more collective vision. And this is work I've been doing with my colleague Kiri Lawson Teaho, looking at how the visions and how a good representation of treaty principles would be done for homeless people. And you can see that it's very similar principles across all the types of housing. What differs is the amount of collective action and the amount of individualism. And the Maori vision and the Maori vision of Papakāinga housing or Whānau Ora housing is much more holistic and much more inclusive of a broader family. So there's real potential here to go beyond what's best practice internationally and for New Zealand to develop its own models. The People's Project in Hamilton have led out New Zealand's first Housing First project, and they've been very successful. Fortunately, we've worked closely with them and they've given us the data, their data from their people. And we've also put that on the integrated data infrastructure to have a look at what does the story of homelessness look like in New Zealand. So we've had a look at their health records, their MSD records, their justice records, and IRD records to have a look to what is the history behind people who wound up homeless in Hamilton. So we're looking at 390 people, the vast majority of whom are Maori again, who wound up being homeless in Hamilton. And what can we say about them? Using the data that is already available to government, and government has collected and collated in Statistics New Zealand. We can see that the group of homeless people, the Housing First group, labelled HF here, 99.2% of them have health records and are identifiable. They are more identifiable than the estimated residence population, which we've used to complete the census now. They're much more likely to appear in justice records and much more likely to appear in social development and tax records. This is not a hard to reach group. This is a group that we have a lot of data on. And the reasons we have a lot of data on people who are wound up homeless is they've been asking for help for an awfully long time. This is 15 years history of interaction with MSD and the amount of times people have been asked to fill out forms giving their name, address, and details and why they needed help to MSD. The Housing First group is in light grey and the overall population average is in the dark line at the bottom. 15 years beforehand, this group is clearly identifiable as high risk. Another 15 years later, their problems have only escalated and they wound up being homeless in Hamilton and having a charity to help them. This talks the systematic failure of the government to work to help these people find the solutions for themselves, and more importantly, to work for equity, because the vast majority of this group are Maori. The health system is 5 years before, and in the health system, this is obvious, particularly in the mental health system. These groups have very high interactions with mental health for a long time before. Similarly, in the justice and the social development sector, everywhere that these people could be looking for help, they were asking for help. The help just didn't arrive in sufficient quantity when sufficiently resourced to not avoid them becoming homeless. So I want to talk about a few conclusions of my work in particular, about the need for Papakāinga housing and for Maori models of what collective public housing looks like, and housing that will deliver equity. We don't even have enough Papakāinga housing in New Zealand at the moment for the numbers to be worth studying. We really need to look at, because there are good solutions that blend the best of New Zealand and the best of the worldwide evidence on how you can do housing. New Zealand badly needs more public housing. Housing is a right, and it shouldn't be something that's so scarce and so bad quality that it's really affecting health. Without equity of housing, you're not going to get equity of wealth, health, or well-being. Housing is a key driver of wealth. It's over half the entire wealth. It's a major social determinant of health, and it's part of all our well-being measures. We need to deliver equity of housing, and we need to do it in a way that is Maori-centric, Maori-led for Maori communities, and Pacific-centric and Pacific-led for Pacific communities. We need to improve the quality of housing in New Zealand. We can't just be giving crap housing to those people who have already been discriminated against for quite long periods of time. It is possible, though, to change these systems, and where these systems have changed, they have delivered really good outcomes. This will save us money. This will save the government money overall, but it'll also boost everybody's well-being. This is a win-win-win solution, and we really need to do it. The principles and the way of doing this already exist. The academia behind how you house homeless people is well known, and that we just need to apply it in a treaty framework I can't emphasize this enough. We need to be leading this out with our communities, and we need our communities to lead it out together. I've just included a bunch of papers for reference back here on the homelessness in particular, and a disclaimer from Statistics New Zealand. All of this is my own work, but they have a disclaimer when you use IDI data. Thank you very much.
Thank you, Nevil, very much for that presentation. I'm going to hold any questions. If anybody has any questions, can you please drop them into the Q&A chat box, and we'll hold them until the end. We now have Dr. Amanda Kvalsvig, who has a video presentation that will be shared with us. Amanda has a background in clinical pediatrics and epidemiology, and she's the lead researcher of the co-search and symbiotic research programs at the Department of Public Health in Wellington.
Tēnā koutou, ko Amanda Kvalsvig aho. I work in the Department of Public Health at the University of Otago, Wellington. I'm pre-recording my talk, and that's because I'm deaf and the webinar format is a little difficult for me to access, but I will be online at the end of the session and I'm very happy to answer questions. I'm going to move to my slides now. I'm going to be talking about COVID-19, equity in the pandemic and response. And I've structured this talk around three main sections. The first is introducing co-search, which is our research collaborative. The second is talking about COVID-19 impacts and inequities, really just giving some examples. This is a huge, huge topic. I'm also aware that some of the speakers today will be covering related areas, and I will talk around those areas, I think, so that we don't get too much duplication. In the final section, I'll be looking ahead to think about next steps, and I'm going to propose 5 equity promoting changes for the pandemic and beyond that we need to start working on straight away. So first of all, introducing co-search. Co-search is short for COVID-19 Research Collaborative. The director is Michael Baker. The lead researchers are Nick Wilson and myself. We're based at the University of Otago, Wellington, with multiple collaborations within the university and also external to it. And this is a highly productive group of researchers. It's really hard to keep track of all those outputs. We're very lucky to have Luke Pilkinson-Ching, who is our photographer and videographer. And many of the images that you will see in this slide presentation are Luke's, including the ones on this slide. Here are some of the co-search researchers, and what a privilege it is to work with such an amazing group of people. Moving on to the second section in this talk, COVID-19 impacts and inequities. People are talking about inequities as the other pandemic that's running alongside the viral one. I think many of us are familiar with this process. Pre-existing inequities are determining risk in the pandemic. But at the same time, the highly inequitable impacts of the pandemic and the response are amplifying those effects. And the existing structural drivers of inequity are ensuring that this process continues unless action is taken to stop it. It won't stop by itself. So that's the challenge we have now, is to break these cycles and achieve equity. I'd like to draw your attention to this very interesting study by our co-search collaborators at ESR. And that very complex diagram is really a visual representation of the process I mentioned a moment ago. So what we're finding is that, as with many other health issues, over time, the trend is for the health inequities to increase. And furthermore, that short-term measures do help, but they can also entrench inequity in the longer term. So it's important not to be tempted by quick fixes. We need to think about long-term solutions. This is a really important point. It's human decisions, not the virus, that determine the course and impact of the pandemic. And I think this is very well illustrated by the graph here, which is showing the total cumulative confirmed cases per million people in a number of different countries. And you can see, looking down the right-hand side of your screen, right at the top right is the United States. You can see South America, United Kingdom, North America, Europe. All of these have extremely high incidence of COVID-19 in their populations through the pandemic. On the other hand, when you look at the bottom right-hand corner, you can see all crunched down into that corner, a large number of jurisdictions in the Asia-Pacific region that have had orders of magnitude fewer cases through the pandemic. Those differences are very stark and they are not accidental. They are about policy and they are about choice. And I think, as everyone is aware, the choice that we have made in New Zealand is elimination. That's our elimination strategy. And Michael Baker likes to talk about the light bulb moment. He was looking at the progress of the pandemic in China early in 2020, and he realized that this very infectious new pathogen could nevertheless be stopped. Transmission could be stopped. And that was a real light bulb moment. As well as understanding that it could be stopped, it's important to understand that it really must be stopped. And that's because of New Zealand's really terrible record in terms of previous pandemics and epidemics. Māori in particular have experienced catastrophic outcomes in previous pandemics in this country. And that was a major motivation for elimination, was knowing that we must not let history repeat itself in this current pandemic. There are multiple dimensions of inequity, and I've touched on one of them, which is thinking about the impacts of colonization and racism in the pandemic. But age has also been a factor. Early in the pandemic, there was a very unpalatable discourse, largely around the fact that it might be acceptable for older adults to have high mortality rates in the pandemic in order to protect economies. And I'm very glad that New Zealand didn't go down that pathway. More recently in the pandemic, we've started seeing discrimination at the opposite end of the age spectrum. Childism is a new term that describes that process where policy decisions determine that adult well-being should be prioritized at the cost of child well-being. I'll come back to that point a bit later. We've also seen gender inequities widening in very concerning ways in numerous countries and in numerous ways. We're all aware that disabilities and underlying health conditions put people at extra risk of incidents and also of poor outcomes. And as we've seen for any other health issue, poverty puts people at risk and also means that they are disconnected from resources that they might need to sustain their well-being in the pandemic. Just a final point on this slide is that a lot of the herd immunity and living with the virus narratives that we're hearing are really not about epidemiology at all. At their base is a value judgment about these populations that are on this slide. And when people talk about living with the virus, there's an unspoken assumption about who they think should be living with the virus. Just adding on to that point, it is comforting for people who don't have disabilities and underlying conditions to think that they might be at lower risk. And the way that that anxiety expresses itself is that when people experience poor outcomes, somebody will pop up and point out that that person or that population had pre-existing conditions. And if that's ever been you, please next time stop and reflect about how that will be heard by those of us who do have a disability or an underlying condition. New Zealand's elimination strategy has been highly effective, and we hope it will continue to be effective in this current outbreak. Elimination has meant relative normality for long periods during the pandemic compared with other countries, and that's certainly worked to reduce the impacts of the pandemic control measures. But nevertheless, our stringent lockdowns are highly disruptive, and the worst impacts are felt by those with the least resources. This is a lovely study that was conducted by our Otago trainee interns, and they interviewed people who were accessing food banks and community supports just after the end of New Zealand's first lockdown. And I'd like to thank the participants who often had quite difficult lives for giving their time to consider the questions and to give their advice. They were asked to reflect on their experience of lockdown, and they were also asked to give some advice to the government about solutions to the problems that they'd experienced. And I urge you to read the paper. These insights were very interesting. And what's really important is that the voices of these people comes through in decisions about our alert levels and how to protect our populations going forward. So thinking about equity and the elimination strategy, we can see that elimination protects vulnerable populations from COVID-19 infection. So it's inherently pro-equity in its aims. But unfortunately, it's not always been pro-equity in its implementation. Luckily, we have a number of fantastic initiatives that can show us the way. And in particular, I'd like to single out Māori and Pacific community responses led by community leaders and providers. And these responses were so prepared for the pandemic in a way that the central government really wasn't. These responses can provide a model right across the country, and it's important to note that this is not just for Māori. What's good for Māori can be good for everyone, and that's the message from our researchers Cheryl Davies and Carmen Timuparata. As well as running this enormous response to support communities, our collaborators at Kukrimrai also had to record what they were doing, evaluate what they were doing, and communicate about what they were doing. So a lot of research activities running alongside. And a very important role for the university here is to support these research activities and help to grow that research community. So looking ahead, the third section of the talk, and this is looking at 5 changes that we need to make. I'm going to go through them one by one, and then I'll come back to this slide. First of all, there must be a truly inclusive decision process about when it's safe to reconnect New Zealand. There are strong commercial drivers that might lead to loosening travel restrictions before protections are in place for those most at risk, and we need to guard against that. We also need to be better global citizens, and that includes protecting our Pacific neighbours. A lot of these actions centre on vaccine equity. I'd like to say a few words about that. Vaccine equity is complex. That's because the risk is complex, and there's an interaction here between ethnicity, age, and risk that is often hidden in the vaccine figures that are being thrown about. We're hearing a lot of numbers and percentages at the moment in terms of our vaccine rollout. But a really key point here is that potentially we could have a very high proportion of our eligible population vaccinated while still having significant inequities in terms of who is at risk. And it's really important that there's transparency in how the vaccine rollout is reported. The key solution here is self-determination that ensures that delivery of the vaccine will be accessible and culturally safe for those key populations at risk. And just coming back to that main point, the people who are most at risk from loosening border restrictions must be at the table when that key decision is made. Secondly, equity must be woven through the pandemic response at all alert levels. And my colleagues and I are strongly advocating for the alert levels to be upgraded, and a key element of that upgrade is learning from our experience so far about the protections and the resources that people need to ensure their well-being and to support them to do what the government is asking them to do. In practice, that means actions and policy to connect and reconnect people to resources. At lower alert levels, that means building resources. And then in the event of an outbreak, as the alert levels step up, the resources must step up alongside, and that step up must be proportionate to need. Third point is we need to make 2020 the watershed year, the year when everything changes for infectious disease incidents and inequities in Aotearoa. 2020 was a very strange year for non-COVID infectious diseases. As well as eliminating COVID-19, we eliminated a large number of other infectious diseases. We also eliminated our usual very high excess winter mortality. So 2020, the major year of the pandemic, fewer people died in Aotearoa than would die during a normal non-pandemic year. That's a really exceptional outcome. We know now how preventable these infectious disease outcomes are. We can't unknow that. We need to act on that. So we need to apply the COVID-19 toolkit to a range of other infectious diseases. Remembering that prevention of infectious diseases is equity promoting. Immediate places to start will be vaccine preventable diseases and winter respiratory infections. We know what we need to do, we just need to do it. The fourth point is to apply the precautionary principle in protecting children in the COVID-19 pandemic. There's some concerning evidence emerging about potential long-term health issues for children. This is not a benign condition for children, and we shouldn't let most or all of our child population become infected with this new pathogen while these risks aren't fully understood. The well-being of children must be centered in pandemic decisions that concern them. So no childism in pandemic decisions. Fifth, and finally, infectious diseases research must be equitable in its process as well as its outcomes. So as well as doing research to achieve equity in outcomes, the research itself must be equitable. And that means that we really need to rethink the current health research funding model to avoid that quick fix solution of short-term contracts. We need to provide sustained support for emerging researchers. We need to grow the research community, and as well as growing it, we need to rebalance it so that it represents our populations more fully. And we need to fund collaborative research communities instead of competitive ones. So instead of compelling New Zealand researchers to compete against one another for small amounts of funding, which is incredibly inefficient, particularly in a crisis, we need to build those networks and collaborations. And there are those 5 points all together on one slide. And I've now come to the end of the presentation. I'd like to acknowledge Michael Baker, Nick Wilson, and all of the other colleagues. There has been tremendous commitment from researchers in responding to the pandemic. Thank you very much.
Excellent presentations from you both. Thank you very much for those. We have had some questions coming through, so I'm going to ask Nevil to answer the first one, which is from Anna Vidal. I'm curious about the barriers to access regarding MSD and Kāinga Ora. If you could change 2 things regarding these organisations, what would they be?
So thanks for the question. MSD, I'd really like an emphasis that it's actually equally as bad not to give somebody their entitlement that they're due as it is to give for somebody to get too much money. I'd like there to be a balance of perspective here, because MSD at the moment, even according to them, there are hundreds of thousands of people who are entitled to benefits they are not getting, and MSD doesn't see that as a problem. I would really like them to see that as a problem. A second thing would be to raise the benefit. To raise benefit levels. There are too many Kiwis in poverty, and that has too big an impact. And if I'm allowed a third thing for 2 things, MSD need to be careful of what bits of the housing system. They've a spread out housing support system at the moment, and MSD is controlling a wait list for something for Kāinga Ora, which is a bit silly considering they don't directly do Kāinga Ora. And then they have New Zealand's second largest benefit is the accommodation supplement, which is being held by MSD without a housing function. So we need to, if we're going to have the idea of putting everything together in MHUD around housing, we need to have the housing benefits there too. Kāinga Ora are actually doing quite well. So there's been a big change in Kāinga Ora's attitude from 9 years of national, and I'll say that quite clearly, where they were trying to run it down, and they saw Kāinga Ora as delivering slums, to a Labour government that's trying to deliver, but they need to deliver faster and they need to build more houses. And we need to look at how we're going to densify. New Zealand cities are quite low density. Kāinga Ora has the scale. We need to build in nice places close to city centres where the jobs are. We need to be building apartment blocks for social housing and mixed social housing.
Great, thank you, Neville. I've just dropped a question to Amanda in the chat, but I'll just read it out for those of you who are listening in. Amanda, why do you think that rheumatic fever figures increased in many areas during 2020?
Sure, that's a very good question, and that was a very concerning finding. I think probably more than one factor might be going on here. One is just about numbers. Rheumatic fever is fortunately quite rare, so the numbers do fluctuate from time to time. So that might be one part of it. Another part of it might be where transmission is happening, and we know that for young children, transmission of infection happens in the home, and that's particularly, as we've just heard from Neville, we have high levels of household crowding. During lockdown, people were in their homes, so there would still have been infection transmission within those crowded households. So I think that could well explain that increase that we saw, and I think there's research going on to investigate that. A third thing is access to healthcare and throat swabbing and antibiotics, and all of those things were more difficult during the early phases of the pandemic, so that may have contributed as well.
Thank you, Amanda. I think we've got time for a couple more. We've had one come in for you, Neville, that's just been upvoted around minimum building standards being quite low in New Zealand. And do you want to comment on whether increasing those standards would reduce inequity?
Yes, so it's essential from a sanity point of view that we increase building standards in New Zealand. And then so New Zealand building standards at the moment, a house built to the building code in New Zealand wouldn't pass the Irish building code from the 1970s or the Swedish building code from the 1950s. We are that far behind. Not only that, we then don't enforce the current code that we have. And it's even when some Irish builder mates of mine came over for the Christchurch earthquake, and I stopped by for a few beers, their discussion of, Christ, this is great. In Ireland, everything needs to be signed off. Somebody's going to check your building. In New Zealand, you just slap a bit of aeroboard on it and tell them it's fine that you did it, and they'll sign it off. So we do really need to look at enforcement, training of the workforce, and making sure that there's a culture of quality rather than a culture of the cheapest price that isn't going to be cheap in the long run.
Thank you. And I think we've got time for one more. A question came in around how housing-related disease is defined and what is included in that definition. Is there a database for collecting that type of information? Question for you, Neville.
So we, Michael Baker and a few others, and there's been a few definitions of it, including the Ministry of Health. They're all very, very similar, and they all include rheumatic fever, bronchitis. It's whether asthma is included or not is your big one. We've published a paper, or Jane Oliver has published a paper looking at rehospitalization and death in New Zealand children. And that's for one of the major, that lists the housing related diseases. Likewise, Katrin Jackson is co-author on a paper that looked at AFI in defining avoidable hospitalizations in New Zealand, and a big chunk of those are labeled the home environment. So there are moderately different definitions, but they all show exactly the same trends, and they're 99% overlap.
Great, thank you very much to you both. I think that's all of the questions that we have had come in. So I'm going to pass back over to Dr. Michele Coleman, who's chairing the student presentations. Thank you.
Kia ora. Kia ora katoa, ko Michele Coleman, tōku ingoa, and it's my pleasure this afternoon to introduce you to our student poster competition. So while this conference has been running, we've been running a poster competition for postgraduate students and students across the whole Division of Health Sciences. So there's over 50 different departments in health sciences at Otago, and we had 18 entrants to this competition of students whose research they felt related to equity. Now they have done a poster and they have recorded talk about it, and you can access those posters on the website where you registered for this conference. We have already had a judging process for the posters, and we have got 3 winners, and the 3 winners are going to present to the meeting now. They each have 3 minutes to talk, and then we have some time at the end for questions. So I'm going to introduce them in reverse order, I think, because people always start at the top of the alphabet. So I'd like to start with Caryn, if I can just get my, yep. So Caryn, if you can share your screen and your slide, and your 3 minutes will start now.
Kia ora koutou. Thanks, Michelle, for the introduction. So we know that the combined pill is widely used in Aotearoa, but the exact user distribution remains unclear. This study aimed to define and describe the population using the combined pill in Aotearoa, New Zealand. To investigate this, I used the Integrated Data Infrastructure, which is a large research database of de-identified data from across government departments, linked at the individual level, and it's managed by StatsNZ. First, I created an estimated resident population of females in Aotearoa in 2018 who are aged between 16 and 50 as of the 31st of December 2018. Only individuals with complete socio-demographic and geographic data available were included in the study population. This left just over 1.1 million individuals, representing 98.6% of the original population. Pharmacy dispensing of subsidised combined oral contraceptives was used as a proxy for use, because it was assumed that if somebody was dispensed the combined pill, that they did in fact go on to use it. So overall, 14.4% of the study population were dispensed the combined pill. The most commonly dispensed pill was Levlin, used by 55% of users, followed by Jeanette, used by just over 20% of users. This number of Jeanette users is high, given that the risk of venous thrombosis when using Jeanette is 50 to 80% higher than for some of the other pills available, such as Levlin. Both before and after adjusting for confounders, differences in combined pill utilisation between socio-demographic subgroups was present. A negative relationship between age and combined pill use was found. And by ethnicity, Pacifica individuals were the least likely to use the combined pill, and European or other individuals the most likely. The relationship between area level deprivation and likelihood of combined pill use was clear, with individuals in the most deprived areas having a significantly reduced likelihood of utilisation. Differences in what types of combined pill were used were also found between socio-demographic subgroups. The proportion of users differed by DHB, with Counties Monaco having the lowest proportion of users and South Canterbury the highest, with over double the percentage of users. Standardisation of these rates by adjusting for confounders somewhat attenuated the differences and resulted in West Coast DHB then having the lowest standardised proportion of users. So in conclusion, there are a lot of people using the combined pill in Aotearoa with clear socioeconomic, ethnic and regional differences in utilisation. As approximately half of all pregnancies are unplanned in Aotearoa, understanding who uses the most common hormonal contraceptive is critical to understanding how to impact pregnancy-related healthcare outcomes. These data are not able to be used to determine causality, so further research is needed to delve into why these relationships exist and what their implications may be. Kia ora.
Kia ora, Caryn, thank you for that. We'll just hold questions until we've heard from our other 2 winners. So I'd now like to invite William Park to address the meeting. Yeah, great.
Kia ora, Dr. Coleman, thank you. Kia ora koutou, no parawai aho, e toira rata aho, ko William Park tuka wingoa. My name is William and I'm a 4th year medical student at the University of Otago, Wellington, and I've been involved with the NZ-RED project since the end of 2020, led by Dr. Richard Carroll. There are plenty of rare endocrine disorder registries in larger nations, which are used to inform clinical practice in Aotearoa, but a national re-endocrine database is unheard of in our motu. We believe that New Zealanders, especially Māori, will benefit from research which we conduct in our own population, rather than generalising results from overseas research. NZ-RED has 3 key aims as listed here on the slide. This accessible database not only means patients are more likely to be involved in clinical trials, but also means we can analyse the ways in which patients present, are treated and monitored over time in our own specific healthcare system. Importantly, inequities that exist in other healthcare conditions for Māori and Pacific patients or those in rural or more socioeconomically deprived areas must be quantified. Only after we describe the health needs of a population can we explore the modifiable reasons for these inequities. We're currently enrolling acromegaly, Cushing's and Addison's patients. The database is prospective and not anonymised to relevant researchers, as we want to be able to invite patients for trials and gather additional patient-provided data. Therefore, enrolment leaves us vulnerable to selection bias until we optimise enrolment. Data is gathered at enrolment and also by searching patient records. It's collected at each specialist appointment and then entered into REDCap software. This data ranges from demographics to diagnostic information, symptoms, complications, treatments, blood tests, and imaging results. Ensuring adequate Māori representation in the governance and research staff is a priority for us. We want to benefit Māori patients by providing evidence to improve equitable clinical care and involvement in trials, but also support an approach which considers aspects of kaupapa Māori. This can be through normalising te reo usage in the registry and research process, a holistic approach such as including quality of life surveys for patients in whānau, and establishing whanaungatanga by contacting every patient individually to kōrero about the project and making research staff accessible throughout this process. We'd also like to develop a te reo name for the registry, guided by mana whenua, and I would like to see some qualitative research on Māori perspectives of living with rare endocrine disorders. The results on the poster should serve as an example of how we may present early findings from the registry once we've expanded to remaining DHBs and not yet interpreted as reliable results. While I would love to be able to present some robust data to you, at this stage we still suffer too heavily from selection bias to make reliable conclusions. In general, however, the characteristics of our cohorts roughly align with what's expected from the international literature, and I've highlighted some key analyses in the poster relating to inequitable delay to diagnosis and treatment that we may later find to be contributing to inequitable outcomes, but further recruitment is needed before any conclusions can be made. Continual focus on equitable outcomes and an approach which includes aspects of kaupapa Māori will lead us towards publishing eventually effective and culturally competent research, especially as it relates to our Māori patients. Ngā mihi, thank you for listening.
Kia ora, William. And thirdly, but not lastly, I would like to invite Hamish Aitken-Buck to present to the meeting. Hamish.
Thank you, Michelle, and thank you to the organisers for the opportunity to present this work today. The rationale for this study, which I should say is preliminary and unpublished at that point, it arises because treatments for cardiometabolic disease, like that for many other diseases, are often based on an understanding of the disease processes in men, and that in turn creates an inequity in the healthcare potential for female patients. They might have slight differences in the underlying causes for the same type of disease. Now, in our lab, one area of interest that we have is in heart fat, and that is because the amount of fat that is surrounding the heart is strongly associated with the risk of cardiometabolic disease. Now, in other areas of fat around the body, fat expansion is known to be underpinned by hypertrophy of the fat cells within those fat depots. However, it is also known that the extent to which those fat cells hypertrophy is also different between females and males, and therefore our research question was to determine whether whether heart fat cell morphology also differs between females and males. And we did this using heart fat that was sampled at the epicardium of the heart and subcutaneous fat that was sampled from just beneath the clavicle to serve as a fat comparison. And we did this in an exploratory type cohort with 88 post-mortem cases, and in a replication type cohort using 76 cardiac surgery patients. And as the correlation matrix in panel B shows that subcutaneous fat cell size positively associated with body mass index, which is something that we expect to see, Heart fat cell size, on the other hand, did not correlate with BMI, but instead positively correlated with age, suggesting for the first time that heart fat cells get bigger with aging. We then separated the post-mortem cases into male and female to determine if sex can then influence this newly identified association of heart fat cell size with age. And as seen in panel C, that positive association of heart fat size with age is evident only in the male post-mortem cases and not in the female. And this is despite there being no difference in the median age or in the median heart fat cell size between the males and females. So then finally, we investigated this apparent sex-dependent association in a separate cohort of cardiac surgery patients that have a more advanced median age. Now, the linear regression analyses in panel D show that age was again a predictor of heart fat cell size. However, now in this much older cohort, being female was now a strong predictor for having smaller heart fat cells, as is then confirmed graphically in panel E, whereby the median heart fat cell size was found to be smaller in the female population, or in the female surgery patients, I should say, relative to the male patients. So to then conclude, we've shown that unlike fat cells from other fat depots around the body, heart fat cell size is not associated with body mass index, but is instead positively correlated with age. Importantly, however, this novel association was evident only in male cases, which then later in life manifests as females having significantly smaller heart fat cells. So then to go back to our original research question, yes, heart fat cell morphology is sex dependent, and therefore research of heart fat must account for differences in females, particularly in older populations. And in the bigger picture, by identifying such differences in females, this will help to determine sex-specific disease processes and potential treatment options, which in turn creates a more equitable healthcare experience for female populations. Thank you all for your attention.
Kia ora. William and Caryn, can I ask you to turn your videos back on? We have a few questions that some of your judges asked us to ask you. So Caryn, what are the implications for women who are less likely to be prescribed, especially Maori Pacific women? What are the implications for them if they're less likely to be prescribed COC?
Well, it's something that really needs further research to look into why those relationships exist, and whether whether there are access issues or whether it's about choice.
Mm-hmm. Okay. Have you got a plan for disseminating the results of your research?
Currently drafting a manuscript for submission to a journal.
Okay, but are you thinking about going back out to populations or people who you spoke to during the research, or?
So this is only a small part of my PhD at the very beginning. So there will be reporting back on further aspects of it later in the PhD.
Okay. And one of our more biostatistically inclined panel members wanted to ask you, in the Latin American, Asian and African group, there was a large shift in the relative risk after adjusting for confounders. They wanted to ask you, was there a particular variable that was important in that adjustment?
I don't have the information on hand on that, but yeah, it would just be to do with the sociodemographic makeup of that population. Sorry, I don't have further information on hand about that at the moment.
That's okay. Okay, William, question for you. Thank you very much for your great talks. They've all been great, but you mentioned that at this stage of the project, the numbers are small, and that individual informed consent is involved. To date, are you seeing any patterns in who is consenting and who's not consenting when you ask them to participate?
So actually, to my surprise, for acromegaly, which has been the focus of our research, we've been calling every patient that we have contact details for. And I think acceptance rate to be enrolled is upwards of 80% for both CCDHB and Waikato DHB.
Yeah.
I haven't noticed any particular patterns. For example, for acromegaly, we've got a really good enrolment rate for our Māori patients. We have, on average, a higher rate of Māori patients enrolled in our acromegaly cohort, which is really good to hear. So we can actually make sure that our data is providing for our Māori patients. For Addison's disease in the Waikato cohort, we only had a handful of Māori patients, but that sort of corresponds with just having lower Māori patients being treated by the tertiary centre at Waikato. So yeah, I haven't really noticed any particular patterns, luckily there.
Cool, thank you. Hamish, a question for you. Can you please ask Hamish if understanding the cardiometabolic disease process in different ethnicities, in addition to sex, is also important for the treatment? And two, are the participants in your cohort from different ethnic backgrounds?
Yes, so they are. At the moment, we don't adjust for ethnicity in any way, and the main reason for that, and of course it is an important research for us to address, particularly with the inequities between within female populations of Māori and non-Māori females and the cardiometabolic inequity there. The reason we haven't done it is because it would be inappropriate at this stage to do it retrospectively, to try and stratify by ethnicity. We haven't performed the appropriate engagement with the local iwi. And then in a post-mortem cases like that, it's completely inappropriate because we haven't got any way of getting consent for that. In fact, we can't even identify, or we have no identification available to us for these patients other than their BMI and their age and a few other things as well. But yeah, other things are not available to us, and it would be inappropriate to do it now. But going forward with an appropriate engagement from the community and with I guess a significant sample size, then I think that sort of thing can be addressed. But we are hesitant to do it at the moment because of the way we have carried out the study thus far.
Thank you. Well, look, I would just like to thank you all. The judges were very complimentary, both about the quality of the work, but also about the level of communication and the ability of our students to actually get across the meaning of their research to a generalist audience. It's a very important skill, and it's part of equity is making sure that information is equitably available to people. So I would encourage the audience to go online onto the website and to have a look at all the posters that are there. Unfortunately, Caryn's is not there because it's about to be published, so she can't have it on there. But please do enjoy reading these posters along with the other posters that are available. So thank you all very much, and a prize will be winging its way to you through the university systems. And everybody, now we actually have some time for a break, and we will be back at 2:15. So thanks very much.